again. My name is Dr. A.N. Hunter. I am your OBGYN for all things related. This is episode 8, The Art of Induction, When, Why, and How. A lot of conversation has been had on social media, especially on mine, on my TikTok. First of all, you can find me on all social media at Dr. A.N. Hunter. There is more to come in the future. Get ready. I'm sort of launching a new platform to do a few things and help a lot of people is the goal. But today we're going to be talking about an induction of labor, what that means, who needs one, who doesn't need one, and what the data tells us. Because I think data is really important for helping guide us and to make the right decision. Your doctor, your OBGYN, your midwife, your provider that's taking your nurse practitioner, your PA that's taking care of you, you are relying on their expertise to help you make good decisions for yourself. So that's the goal of this episode today. So like, subscribe, all the things as we kind of get rocking and rolling. So one of the big things to know is what exactly is an induction. So essentially there's a few ways to deliver a baby, right? One hand there's C-section, the other hand there's vaginal delivery. And for vaginal delivery, normally what happens is if someone is in labor, so the definition of labor is not only contractions, regular contractions, but also cervical change. So someone's changing their cervix and they're having regular contractions, they're in labor. Whether they're in early labor or active labor, to be said, but to be found. But regardless, labor is labor. But an induction is we are trying to give you medication to help you get into labor, right? We're trying to do all the things we can to make your body go into labor so you can have the baby for a number of different reasons. The one thing that I've seen and heard from many individuals is that inductions are not necessary. I'm going to tell you this right now. Inductions are necessary. Part of my job and the job of anybody that's taking care of any pregnant women around the world is to help you. Ultimately, our goal is to help you deliver that child, go home with that baby in your arms. Now, that is not the case for everybody. Some babies go to the NICU. Some babies don't make it. But ultimately, we're making all these choices, doing all these things because we want you to leave the hospital safe and sound. We want your baby to leave the hospital safe and sound. We'd also would love for your family to recommend others to come and see us because you left safe and sound and the baby left safe and sound. So that's our ultimate goal. There is no financial gain out of this. Obstetrics is not a huge money maker. So we're not doing this for the money. We're not doing it for the fame. Literally doing it because we love it. All those involved in this do it because we love it. Because the moment you take care of somebody who has lost their child, a lot of people would stop this because it is traumatic. It is a lot. I remember every single instance of every mom, especially full term, that I have delivered who's lost their child. Almost every single one. But that's besides the point. So today, a couple of things to know. For an induction, first off, one main reason, well, first of all, when you look at the data and you want to look up who needs an induction and why, who are the most common people that need an induction? Those who have high blood pressure disease, those who have diabetes, either gestational or pre-gestational, and with gestational diabetes, either on medicines or not. Those who just want to deliver their baby earlier than their due date or earlier than 41 weeks. If the baby has some sort of anomaly, meaning it would be more advantageous for the baby to be born in a more certain time frame to get all of the care that it needs. There's certain in certain institutions, you sort of try to plan these things to get all the folks involved that need to intervene on the baby at that time. And then other causes, like mom may have some sort of heart disease or have something called congestive heart failure or lupus or something like that. So for some reason, there's something that is more dangerous to stay pregnant than to have a child. And so that's the point of the induction. The big question, though, is if we induce you, then will it fail? Will you end up needing a C-section? So, if you look at like moms who want to have a baby and, they need to be induced, there is this fear that like, oh my God, if I be induced, I might as well just sign up for a C-section because I'm gonna get one anyway. But that's not really the case. It's hard to look at data to figure out like what's the failure rate for an induction. What's better to look at is who has a higher risk factor to not make it to 10 centimeters, be able to push a baby out, right? One of those risk factors is high BMI. Some data says over 30, some data says over 40, BMI over 30 or BMI over 40. I know BMI is a terrible indicator of sort of people's status as far as like weight class, weight status, but it's the best we got right now. So some studies say 30, some say 40, but in general, a higher BMI, those ladies tend to have a higher rate of C-section. Women who are over 40, I have theories about this. I don't know, if my theories are true or not, but there's something about women over 40 either needing to be induced or even going into labor, having a higher rate of C-section regardless. Those who have high blood pressure, especially chronic hypertension, meaning you have high blood pressure either before pregnancy or early on in pregnancy, before 20 weeks, that is also an indicator. And then for some reason, I've seen a lot of data about height. Less than average. So I think the average height for women is about 5'4". I could be wrong, 5'3", 5'4", something in there. But women who are shorter than that, apparently that's a higher risk for a C-section. I've seen, a number of different women deliver babies from the tallest, like I think one lady I took care of was like 6'5", to somebody who was like 3'4", 3'5", something like that. So someone very short stature, but regardless, those are risk factors. And so you want to sort of take into account the whole picture when it comes to, am I at a higher risk of needing a C-section versus not? The other thing is you look at is, if you're going to be induced, what is the process of an induction? So an induction takes a long time, okay? Let me say this again for the people in the back. Inductions take a long time. They are not quick. They can take, especially for your first child, they can take 2, 3, sometimes 4 or 5 days, because the early part of labor up until 4 or 5 centimeters can take days to get you there. So if you look at data to figure out like how do you get someone induced and successfully deliver, and also how do you get them there faster? So there's certain options that you have. There's one medication called misoprostol, or Cytotec is an old school name. And misoprostol can be given all over the place, literally in like every hole. You can take it by mouth, you can take it and let it dissolve underneath the tongue or in your cheek. It can be placed vaginally, it can be placed rectally. But most places around the country that I know of tend to, if they're going to give you misoprostol, they tend to want to give it to you orally by mouth, swallowing it or letting it dissolve underneath the tongue, or vaginally. And a variant of misoprostol is something called dinoprostone, or I can't remember the name of it, but it's like this little strip of paper, but it has the same kind of medication in it. And essentially what your provider does is they put it up either in the cervix if they can get it in there, or up underneath or wrapped around if possible. It's very expensive, so not a lot of places are turning away from it because it's super expensive. But essentially what happens is that it's a cervical ripening agent. So if you show up to that hospital or someone checks your cervix in the office, let's say you need to be induced at 39 weeks, and your cervix is like a centimeter, there's something that we use called a Bishop score. Med students hate this because they get tested on it all the time, and it's very silly because of to be tested on it seems wild. It's really just put in a calculator, but essentially we take all these different components of your cervix, how soft it is, how dilated it is, how flat it is or effaced it is, where it is in position to the opening of the vagina. Is it more posterior? Is it more anterior, meaning closer to the opening of the vagina? And then where is the baby in relation to the cervix? Is the baby's head really high up when you check the cervix, or is the head really low, sort of engaged in the pelvis? All of these things are indicators of how successful an induction will be, and really using different induction agents will be. And so some of the early things are cervical ripening. So we're trying to do all these things to get your cervix more ready for labor. A cervix that's ready for labor is a cervix that's more flat / effaced, more dilated, ideally like 3 centimeters plus, and then where the baby is more engaged in the pelvis, meaning that if I push on the head, it doesn't kind of float away. If I push on the head is like stuck. It's like engaged in there, almost socked in, ready to roll. And so we're trying to do all this stuff to get these things happening. So misoprostol is one way. Another way is something called a Foley balloon or a Cook catheter. I think Cook catheter is what I use at my hospital, but essentially You take this balloon or catheter, whatever it is, and you tunnel it up into the cervix. Okay, the cervix is like a tube. When you're early on, you're not really in labor. It's like a long tube, and you tunnel it up here. And then when it gets to the top, you blow it up with a little balloon, and it's on top of the cervix. There's an internal os, which is where the baby sits on top of, and then the external os is what you first feel when you're checking the cervix. And so what you do is you tunnel it through there, and you blow the balloon up, and then you have it be pulled down, and it gets taped to your leg, or different places do different things. You tug on it. Essentially, you're trying to create pressure. So as that balloon comes out, it causes the cervix to open. It's called mechanical dilation. It is not fun. It is not comfortable. A lot of people hate it, but it is effective. Many times, if you do it right, it's in the right spot and it really works the way it's supposed to. When it comes out, you're like 4 or 5 centimeters. Now, that's like sometimes we call it a Foley 4, meaning you're not really 4 centimeters because labor made you 4. We're really 4 centimeters because the balloon made you 4. And so, we kind of work around that. And then another way, as far as induction, is you can use oxytocin or pitocin. And some people call it the evil pitocin. Pitocin kind of stinks sometimes because it makes contractions hurt more. That's the goal, right? When you're trying to have a baby, you want a lot of power, and you want that power to come from someplace. And naturally it should come from you, but sometimes you need a little help, right? And induction means your body isn't doing it yet, so we got to make it jump start, make it go. It's almost like jumping a car. Once we can really get a car jumped and get the battery turned over, now the car can take over. Now your body can take over and do labor on its own. But we kind of sometimes have to like push it forward constantly. We have to kind of push it to get you there. So pitocin kind of helps with that too. Your brain produces oxytocin on its own naturally. You meaning all the women who are watching this, premenopausal women, not menopausal women. So you produce oxytocin naturally, and oxytocin is stimulated by the trigger for labor, and essentially it's released from a certain part of the brain in the pituitary, and then it kind of travels down and then hits the uterus. And what happens is, as it hits the uterus, it causes you to contract, and when you contract, you release these hormones, and those hormones sort of create this feedback loop, and you continually do it. Well, if you're not contracting, then your body's not really producing oxytocin. And so then what do? Exogenously, outside the body, we give you oxytocin in your IV. And so, there's this idea, this problem with like doing all these things, like it's unnatural is what a lot of people say. I'm gonna tell you something. A lot of things in life are not natural, meaning the only natural thing is that if you just went into labor on your own without any intervention, with no one touching you, no nothing, you just spit out a baby, your bleeding kind of stopped on its own really quickly, you don't need anyone to touch you, kind of do your thing. But a lot of times that does not happen. You could have the perfect delivery and all of a sudden you just start hemorrhaging, you just start bleeding everywhere. Well, I have to then do unnatural, right? I have to give you medications to help you. Unnatural is not bad, right? We have to get out of this mindset that everything has to be natural from the earth. We have to get back to what people have been doing for thousands and thousands of years. Let me tell you something. For thousands and thousands of years, babies have died. Moms have died in birth. If you look at indigenous places in the world and you look at maternal death rates, a high risk of birth is hemorrhage, bleeding after delivery. That happens to a lot of women. If you don't have medications available to help save their lives, those women will die. So this whole idea of like natural everything, I think sometimes endangers you a little bit, because there is this desire to get this natural thing while putting yourself at risk, putting your child at risk. So to me, ultimately, what I think everybody wants when they are pregnant and you then have a child, what your ultimate desire is to do the perfect thing for your child, for both you and for your baby, right? Your goal is to take your child out of that room. Many people's goal is to then raise that child to be the next Bill Gates, the next like superstar, right? You have this perfect dream for that baby. Well, from pregnancy side, before you've even seen that child's face, to the day that they decide to do whatever amazing things they're going to do. Before you get there, there's a lot of steps to meet, and sometimes an induction is one of those things to get you there, and that's okay. And it's okay for some people. It's totally fine. Okay. The one thing I do want to address is this idea that like inductions are not necessary, and so people believe that due dates are fudged, they're not quite right, and because they're not really good, I can stay pregnant for till 45 weeks or something wild. And I would challenge that. Ultrasounds today are 1,000 times better than they were 30 years ago. Dating in an ultrasound is so good. So if you're looking at due dates, right? One of my pet peeves, I think, is when women get, a lot of my pregnant ladies get ultrasounds during pregnancy. Their ultrasound reports always spit out a due date. That due date that comes out in your ultrasound report does not mean that someone's changing your due date. Your due date, the most accurate due date, is the earliest ultrasound where you can see a little peanut, a little baby with a heartbeat. That is the most accurate as far as figuring out what your due date is, ideally. Now, some MFMs would disagree with me when it comes to like later on trying to figure out if babies are small, yada, yada, yada. But ideally, if things are perfect, you can get an early ultrasound, 8-9 weeks. You see a little peanut with a heartbeat. That is the most accurate of an ultrasound you can get, because babies grow at a roughly around the same rate around that time. As babies get bigger, the rate of growth changes. They can get really big, their growth can slow down, or can kind of stay kind of in the middle. So the accuracy is off if you just wait till later on to get your first scan. So if you get your first ultrasound early on, 10 weeks or less, then that ultrasound is pretty good. I'm gonna tell you right now, it's pretty accurate, pretty good. So then when you look at who has the least amount of issues, whether from natural labor or being induced, as far as delivery timing. And I'm going to tell you, it's those ladies between 39 weeks to 41 weeks. That is like the pristine time to have a child. Like that is like chef's kiss, golden time to have a baby. Here's why. Some ladies have to be induced early, and I'm not going to go into that because sometimes there are medical situations where that baby needs to be, it's safer for the baby to be out more so to be in. And so that is sort of a discussion between you and your provider. But I'm going to talk more those deliveries past 41 weeks, those moms who are further on to 41 weeks. There's a few risks to know, okay? We're going to talk risk to mom first and risk to baby. The big risk to mom, okay? One of the biggest ones is a risk of hemorrhage. So the risk of hemorrhage is 85% more likely for you to have a hemorrhage if you deliver greater than 42 weeks. So if you have a mom, and I talked about this in a prior episode, a YouTube video, who wants to deliver their baby at home and they're more than 42 weeks, like get ready for the stuff because you're going to need some intervention because bleeding is legit. Placentas are an organ that are fantastic at supplying your child with all the nutrients and all the blood supply and all the things that it needs. But it does run out, right? There is an expiration date on a placenta. It doesn't last forever. It will deliver itself sometimes before you want it to. And so that's a part of it too. Another big risk is, of course, increased risk of C-section. Why is that? There's a higher risk of something called meconium. And meconium is where the baby poops on the inside, where sometimes the baby can poop on the inside, swallow said poop, not really love that process, and the heart rate can do some wild things, and the baby may not tolerate labor very well. The other things that comes with the longer you stay pregnant, the bigger your child gets. So all babies won't fit through the vagina. I'm going to tell you, a 15-pounder, I'd be surprised. Now, I'm not going to say it's never happened, but rare. Let me tell you that right now. Rare. Okay. And then the last thing, which is very interesting when I looked at the data on this, is that you're actually at a higher risk for a laceration, for having a tear in the vagina. So that's one of the big fears a lot of people have when they're going to deliver a baby, is like, oh my God, I'm going to have this really bad tear in my vagina and it's never going to be the same. Well, the smaller your tear is, the less likely you have any long-term issues from that. And I'm speaking very generalized. That's not the same for everybody. So if you do have issues, please call your OBGYN or go to a urogynecologist to get that addressed, because you shouldn't have to live with that for the rest of your life. But that's another story for another day. But regardless, I thought that was so interesting, is that you have a higher risk for getting a tear in the vagina. It's interesting. And so now let's talk about risks for baby. Okay. So one big risk, I think is probably the biggest one. Probably if I was a pregnant woman, I'd be like, do not leave me pregnant past 41 weeks because of this risk. There is a big risk of what's called stillbirth, meaning let's say you're going to your provider, you show up to an appointment and your baby does not have a heartbeat. You show up and that baby doesn't have a heartbeat. There is no stat C-section that I can do to save that baby's life because I don't know when the heartbeat stopped. I don't know if it just stopped or if it stopped a week ago. I have no idea. Stillbirth is probably one of the scariest things I think that can happen to a mom. It's one of the scariest things that I've dealt with in my career thus far. So I always tell people, I don't gamble on anybody's child. And I don't want you to gamble on your child because I wouldn't gamble on my own. So there's certain things when you talk about taking risk, or like, is it, risk benefit analysis? Is it worth the risk? Sometimes it's just not worth the risk. Ultimately, whether you have a C-section or not, like, as long as you take that baby home in your arms, that's the goal. That's what we want. And so I'm gonna push that so much because C-sections are not the devil. I know I push a lot of I'm very pro vaginal delivery on all of my social media posts. Huge proponent of vaginal delivery, which is why I really am a big fan of operative deliveries using forceps ideally, because I just am very comfortable with forceps. But regardless, delivering the baby and having a beautiful child is the goal. Okay, so stillbirth, the number one risk in my opinion. The other big risk, we already talked about this earlier, a big baby, and the risk of a big baby really jumps up when you get over 42 weeks. We talked about meconium. Well, there's something that you diagnose the baby with after the baby's born called meconium aspiration syndrome. That lands a lot of babies in the NICU. So not what you want. There's also a high risk of the baby going to the NICU. If you want to look at numbers, your baby's 2 times more likely to need to go to the NICU when you deliver over 42 weeks than less than 42 weeks. So food for thought. And there's a lot of other baby outcomes, something called respiratory distress syndrome, transient tachypnea of the newborn, things like that. Higher risk when you get further past your due date. And then the last thing, I spoke about the placenta and how it has sort of a due date itself too. For the nerds in the back, like myself, who kind of nerd out about interesting things, I thought it was very interesting. I looked up and I wanted to see what studies have people been doing to kind of look at what happens to the placenta when you get past your due date. And one big thing is there's this increase of something called oxidative stress, which essentially just releases this is a very generic term, it's not quite true, but toxins, right, within the placenta. There's a increased rate of cellular aging, meaning the cells within the placenta start to replicate and age faster than they should. And then there's even some necrosis, meaning dying of part of the placenta. And all of that leads to decreased rate of oxygen supply to the baby and decreased functionality of the placenta. So, in the end, it's you get to a point to where risk benefit wise, it's not really worth the risk to stay pregnant that long. This whole idea that I have to go into labor on my own, we really get focused in on that. And I think that sometimes social media and family really put the focus on you laboring on your own and less on just enjoying the process, right? Just enjoying, the end, because now you're going to transition to a new part of your life. You're going to go from being pregnant to now taking care of a child to then maybe even think about pregnancy again in the future. And so when you focus in on this small, to me, in my opinion, seems very small minutia of this is the kind of labor I want, when in the grand scheme of things, if your goal is to have a big family, to take those risks and a risk of you not being here for those kids, or this child not being there for the rest of the kid, to me, it's not worth the risk, in my opinion. So, I think inductions are fantastic when you do them correctly, when they are definitely indicated. And I also, on the flip side, will say we now have good data to show that first-time moms, if you don't want to wait until your due date to have a baby, if you want to be induced at 39 weeks, that's okay. The data tells us that is okay. The risk to you and your child is not any greater than if you were to be induced at 41 weeks. If anything, I would challenge it and say the risk of being induced at starting at 41 plus is probably higher for you, complications for you and your child, than it would be for you at 39 weeks. I've seen that personally, and I've just seen that across the board. So there's nothing wrong with you deciding what you want to do for your child. I will say this time and time and time again. The goal is for you to be comfortable with your plan, with your care, with your provider. Last thing I'll say is, a lot of people will push that you need to do this birth plan business, right? You need to harp out and tell everyone that this is what you want. You want all these different things. Have conversations, piece it out throughout your visits. Learn where you're going, what their practice is, what their thoughts are on these plans, because certain things they can't abide by. The hospital that I work at, you cannot deliver there if you're not going to have an IV. It's too much of a risk. There's too many things that can go wrong if you don't have an IV. It doesn't have to be hooked up to fluids, it doesn't have to be hooked up to anything, but it just has to be there, it has to be in and available. Because when I need to save your life and do things to save your life, when your nurse needs to do things to try and save your life, the IV can be it. That can be the thing that takes us from life-saving measures to you leaving this world. And I don't want that. Neither does anybody taking care of you or your child. So that's inductions as a whole. I would say, please, please, please talk with your providers, talk with your doctor about these things. Thank you again for tuning in. I'm Dr. A.N. Hunter, your OBGYN. Tuning in. This is Mentor Moments, Growing Beyond Failure. Find me again on all the social media platforms, wherever you can find me. Thank you. Have a good one.